Good day everyone. I am Dr. Kandati Manishwini, postgraduate in Department of Ophthalmology, Government Medical College, Kadapa. Today I am going to discuss about management of basal cell carcinoma in eyelid. My aim is to assess the efficacy of wide surgical excision with 4 mm clear margin followed by reconstruction in preventing recurrence of basal cell carcinoma and cosmetic appearance when there are no frozen section facilities available. And my objectives are to assess cosmetic outcome with surgical management, to assess post-operative recurrence after 2 years. Materials and methods. Coming to inclusion criteria, all cases of basal cell carcinoma which are surgically treatable are included in the study. The following are the exclusion criteria. Small and superficial tumors for which chemotherapy is chosen instead of surgical excision. Basal cell carcinoma involving orbit. Exenteration is done instead of surgical excision, and distant metastasis. Coming to introduction, basal cell carcinoma is the most frequent malignant lid lesion in the world. 80% of the basal cell carcinomas occurs in the head and neck region, of which 20% occur in the eyelids. In the periocular region, it represents more than 90% of all malignant tumors. Basal cell carcinoma displays a considerable diversity in appearance, both clinically and microscopically. The tumor favors in lower lid, approximately in 70% cases, and in the medial canthus, the upper lid, and the lateral canthus, following in the descending order of frequency. Synonyms to the basal cell carcinoma are the rodent ulcer, basal cell epithelioma, basileoma. The malignant cells develop from germinal cells of the epidermis. This layer lies above the basement membrane and separate the dermis from epidermis. Tumor enlargement occurs when basal cell increases in size and extend into the dermis to form a nodular tumor. Epidemiology and etiology. Exposure to ultraviolet rays, mutation in TP53 tumor suppressor gene, immunosuppression, focal trauma, ionizing radiation, previous radiotherapy, chronic exposure to toxic substances, low socioeconomic status, family history of skin cancers have high incidence. On clinical examination, tumor will be having a pearly edge and a pink color, occasionally presents as ulceration and bleeding. The tumor size is positively correlated with age. Other findings will be mass fixation to orbital bone, limitation of ocular motility and globe displacement. Other possible symptoms includes immobile lids, epiphora and ptosis. Coming to investigations, computed tomography with bone window visualizes bone destruction. Magnetic resonance imaging visualizes soft tissue changes and perineural invasion. As clinical symptoms and findings vary, final diagnosis must always be histopathological examination with biopsy. The following are the histological types of basal cell carcinoma. Following are the management modalities of basal cell carcinoma: surgery, radiation therapy, photodynamic therapy, pharmacological therapy, combination therapy. Most recommended treatment modality is the surgery. Techniques are electrodesiccation and curettage, excision surgery with 4 mm wide margin and lid reconstruction by direct closure, canthotomy and cantholysis, tensile semicircular flap within the orbit, Cutler bed mucocutaneous flap, Hughes tarsoconjunctival flap, Mustard's cheek rotation flap, and transposition cheek flap. Most micrographically controlled surgery: cryosurgery by cryoprobe or liquid nitrogen spray, -25 to -30 degrees Celsius, laser ablation of the tumor. Coming to radiation therapy, used in advanced extended lesions and in those where surgery is not suitable. Postoperative radiation is also an adjunct in aggressive tumors which were treated surgically but failed to clear margins. Extended beam radiation therapy employed in a dose of 3000 to 6000 centigrades over a period of 5 to 6 weeks. Coming to photodynamic therapy, aminolevulinic acid applied and activated with specific wavelength light to destruct the tumor. In cases of tumor recurrence with tissue atrophy and scar formation, surgically unfit patients for oculoplastic reconstructive surgeries, ill-defined border tumors, tumor requiring difficult or extensive oculoplastic surgeries. Pharmacological therapy. Topical agents used in the treatment of basal cell carcinoma include topical and intralesional 5-fluorouracil, imiquimod, which is best useful for superficial basal cell carcinoma of less than 2 cm diameter, mitomycin C, vismodegib. Topical 5-fluorouracil or intralesional interferon alpha 2 as pre-treatment for most microsurgery to reduce the size of tumor effectively is used as a combination therapy. These are the case illustrations showing pre-op, post-op after 1 week, post-op after 6 weeks, after the procedure of 4 mm excision with transposition cheek flap under local anesthesia. Post-operative period was uneventful, no recurrences noted. A 50-year-old male patient with nodular ulcerative mass on left upper eyelid, excision and reconstruction done by Cutler bed procedure with 4 mm wide margin. This is the stage 1 Cutler bed. This is the stage 2 Cutler bed after 4 weeks. No recurrence was noted hereafter. Patient education is essential in prevention of recurrence. Avoid sun exposure, ionizing radiation, regular use of sun protecting clothing when outdoors. Avoid sun exposure particularly during the middle of the day. Sunscreen of SPF 50 is recommended. Intensive sun protection before age 18 years can reduce non-melanoma skin cancers by 78%. Coming to the conclusion, wide excision by 4 mm margin followed by reconstruction is effective in management of basal cell carcinoma of eyelid with no recurrence in future when there are no frozen section facilities available. Thank you.